Hi, everyone. Okay, final PowerPoint for week 2. This is care of adult with ocular disorders. Again, I already did a generalized PowerPoint over the readings and the major ocular disorders to really pay attention to, especially in terms of emergencies. In my intro PowerPoint, that was an overview. This goes more into the nitty-gritty of each particular ocular disorder. So here we go. So first thing first is just a review of the ocular anatomy. Make sure you know the different parts of the eye, especially when you're looking with the light over here at your optic cup, your optic disc, your arteries. And you want to just make sure you're conscientious of what normal looks like versus abnormal, okay? Okay. Next. Okay, so review. So subjective and objective exams. All right, so common subjective ocular data. So basic stuff that you're asking your patient. Have you had any changes in the vision, any eye pain, discharge, or headaches? Any known eye disorders, for example, cataracts or macular degeneration? Does the patient use anything in their eyes? Eye drops? Any history of eye surgeries? Do they have an eye doctor, aka an ophthalmologist? When were they last seen? Do they wear corrective lenses? And when did they start wearing the corrective lenses? Do they wear glasses? Do they wear contacts? What kind of contacts do they wear? Do they wear daily contacts? Do they change them every 2 weeks? Are they disposable? There's all kinds of corrective lenses. You want to be very conscientious of what kind your patient wears because you want to talk about appropriate contact lens etiquette in terms of making sure they're cleaning their contacts at night, they're taking them out every night. You don't want to leave those in when you're sleeping. You want to make sure they're checking their contacts for any rips or tears and changing them like they're supposed to be. And just making sure they're following up with their eye doctors every year to make sure their prescription for their contacts or glasses are actually accurate. In terms of common exam depends on when you go to do your ocular exam, you want to make sure your exam is dependent upon the patient's age, any comorbidities, their presentation, and what they're presenting with in terms of their symptoms. So common ocular exams, which we got into already, was your external eye exam, just looking to see what's going on in that eye. Is there anything in there? Do you notice anything obvious, redness, drainage, anything like that? You're going to do a full head, ears, nose, and throat exam, eyes, ears, nose, and throat exam. You're going to do a pupillary exam, which includes your pearl up, pupils equal and reactive to light and accommodation. You're going to make sure you elicit the red reflex. You're going to look at the fundoscopic, you're going to do fundoscopic exam, dilated versus non-dilated. You're going to do your exam for visual acuity with your Snellen chart, color vision, visual field, extraocular eye movements, your Woods lamp and fluorescent staining if you're concerned about anything in the eye, tonometry, and then your slit lamp exam, which you probably won't do, but you should just be aware that it does exist. Okay, so common ocular procedures, which we went into with your YouTube videos, so you can really see how each one is done. Fluorescent staining, removal of foreign bodies with the eye irrigation, eversion of eyelids to scoop out any kind of foreign bodies with a sterile Q-tip, and then of course, installation of drops. Ocular pearls. Okay, so what does that even mean? Clinical pearls or ocular pearls. So the pearls will be anything that you really should make sure you know, because the likelihood is it will be on your boards. Not to mention, obviously, it's important to know for clinical practice, but specifically in terms of passing your boards, this is information you need to know. So the Snellen chart is a very important thing to know, pretty basic. This is obviously you're checking for visual acuity with any kind of ocular complaints. It's a standard of care. Keep in mind that because it's a standard of care, if you don't do it, then it's actually, and it leads to a negative outcome, technically you're going to be held liable for that because you should have done it. You're definitely checking visual acuity if you have any patient that comes in with acute vision changes or has any significant issue suddenly with their vision. If the patient wears glasses, first you want to assess with the glasses on and then note the corrective lenses and document what their vision is with the glasses. Red flags for ocular complaints. Okay, so again, these are emergency things that you need to be conscientious of when it comes to eye complaints or ocular complaints. If they have a sudden acute change in their vision, if all of a sudden you have a patient had no issues with their vision, they come in and all of a sudden they can't see, or they have sudden blurry vision or sudden eye pain, especially if there's any nausea or vomiting associated with it, big time emergency, right to the emergency room, you call an ambulance. They cannot drive. Photophobia, like sensitivity to light, inability to move their eye through full range of motion with their extraocular movement. If they have like a lot of floaters, if they're seeing like a lot of floaters, or if they have acute vision distortion, like these are all emergency that need to be referred immediately. Okay, so here we're getting into dry eye and excessive tearing and what it's associated with. Again, I'm not going to read these slides to you. I'm just going to go through them quickly just to point out if there's anything specific that I really want you to be conscientious of. So one thing here that's important to note in terms of excessive tearing, if it's noted only in one eye or unilateral tearing, you're going to want to think something is going on with that particular eye, whether it's a foreign body, an abrasion, an obstruction, or possibly the beginning signs of conjunctivitis. Yes, you can get conjunctivitis in one eye, but the likelihood is it will, because it's so contagious, it will probably go to the other eye as well. Okay, so we have eye pain. You want to look at traumatic versus non-traumatic. Visual changes. Again, if the change is acute, likely the etiology is also requires immediate attention by an ophthalmologist to prevent permanent vision loss. That's the key here, guys. Like in terms of the ocular stuff, the biggest thing is to know what is an emergency, because you don't want your patient to lose their vision because of whatever's going on. So the quicker you get help by a specialist, the better off the patient will be. Okay, so again, big red flags and acute vision impairment loss. So acute meaning it happens suddenly. Retinal detachment, glaucoma, giant cell arteriitis, neurological conditions such as a CVA, a brain tumor. CVA and brain tumors are very big red flag. Like the acute vision impairment is a big red flag for a CVA or a brain tumor. Central occlusion, optic neuritis, trauma, worsening disease, especially when it comes to diabetic retinopathy or macular degeneration. And again, when it comes to worsening disease with these two particular ocular disorders, diabetic retinopathy and macular degeneration, you need to deal with it because they will lose their vision if you don't. And of course, if they develop any infection, that could be an indication of why they have acute vision impairment. Okay, red eye. So red eye is literally your conjunctivitis. Your conjunctiva is red, and it could be from a couple of different things. All right, there's multiple ocular disorders with red eye. It can be categorized as painful or non-painful. Typically, a painful red eye or a red eye with vision loss is a red flag pointing to a significant problem. So keep that in mind. Again, if something is sudden or severe, that is not a good sign. They need emergency help. Okay. So in terms of emergent ophthalmology referral and red flags for eye pain, again, your patient complains of acute vision loss and non-traumatic eye pain with exam findings of, so this would be acute vision loss without pain. So, or non-traumatic eye pain. These would be corneal ulcerations, suspected herpes zoster of the eye, which actually can be very painful. Hazy or opaque cornea, irregular pupil shape, papilledema, muscle paresis, all of these things, you need to make sure they get follow-up, especially if, they get like some corticotherapy and they're not improving. Okay, so here's the different causes for red eye. This diagram is pretty intense. We talked about the different types of conjunctivitis, whether it's allergic, bacterial, or viral. Super important for you to be able to differentiate of these three, because number one, you need to know which one it is, so you know exactly how to treat. Because some you don't treat allergic and you don't treat viral, but you do treat bacterial, and bacterial is usually acute. And these tend to be there usually is a question on the boards about conjunctivitis and differentiating it from bacterial versus viral versus allergic. So really learn these slides. Again, more painful red eyes, differential diagnoses. Okay, here's examples of what differential diagnoses, what does that mean again, right? So we have this particular symptom, the painless red eye, right? And here in these particular slides, she lists what they call differential diagnoses, meaning it could be this diagnosis, it could be this diagnosis, it could be bacterial, it could be viral. You never want to stick yourself in a box and be firm on a diagnosis until your treatment plan actually shows that whatever treatment you're putting for that particular diagnosis is actually working. Be open to the idea that you may not be on track for the particular disorder you think it is. So just keep in mind, there's all kinds of painful red eye differential diagnoses. You've got open acute angle closure glaucoma. You've got scleritis, corneal abrasions. There's all kinds of diagnoses that could come with a painful red eye. That's why it's so important for you to, make sure you know the key factors for each one, the key symptoms. Okay, so many algorithms exist for red eye, may be differentiated by other symptoms, pain, discharge, unilateral versus bilateral, etc. Find an evidence-based product that you prefer. Okay, so what is an algorithm? An algorithm is basically a little tool to help guide you in your diagnoses. So this is in particular for an eye. So here we did all of these things before we even go to this algorithm. First, we got our history and physical, including an evaluation of the visual acuity, fluorescent staining, tonometry or oblique flashlight test, swinging flashlight test, and the pen light test. Okay, did the corneal uptake identify on the fluorescent stain? So when you put that dye in the patient's eye, did you notice that it pooled anywhere? If yes, pattern of uptake, then you have to figure out, well, how did the dye, how did the cornea uptake the dye, or the stain, I should say, and then you go from there. Based on was it dendritic, linear or geographic, or punctuate or pinpoint, will guide you in terms of what the probable diagnosis is. Versus no, was there no uptake of the stain? Then no, then we need to find out, is there any evidence of elevated intraocular pressure? If no, do we have a decreased visual acuity? If yes, then it probably is photophobia. If no, it's probably hyperemia. So these are really helpful because, again, it's evidence-based practice, and it really guides you as to how to think based on the symptoms you're and the data you're getting based on your patient's symptoms. So find an evidence-based product that you prefer and have it handy in your practice. Okay, so this goes into blepharitis. All right, we talked about this a little bit in the treatment plan. Non-ulcerative versus ulcerative. Dacrocystitis, blockage and infection of the lacrimal duct. See his like a little puffy here? Again, first thing you're doing when you're looking at assessing eyes, look at them. Look at inside, around, figure out what's going. Just looking at the patient's eye really can give you a lot of information. So localized tenderness, erythema, and edema. See, he's puffy here and he's red. Purulent material from the nasolacrimal duct. So what is the prescription for this? Warm compresses and topical antibiotics and systemic antibiotics. Okay, after you start the antibiotic therapy, you definitely want to refer to an ophthalmologist. Okay, so surfer's eye. This is a common thing. My fiance is a surfer, and I have to tell you, it's a big thing in all the surf world. Like really good sunglasses, they have to wear them because they're in the sun constantly. This is really caused by exposure to UV light, wind, dust, and fibrous growths on the conjunctiva. So obviously primary prevention in this case would be to avoid excessive sunlight and wear protective eyewear. Okay, so you've got your hordelum and your chalcyon. So the hordelum is the stye, it's acute, and it's usually a tender lump within the eyelid caused by inflammation. And then the chalazion, I'm not sure if I'm saying that correctly, but it's mostly found above the eyelashes on the upper lid. So this is more the chalazion, this is more the stye or the hordelum. And then you could get them inside of the lash line. It's pretty painful, to be honest with you. In the chalazion, it's usually a blocked or oil gland. The stye, on the other hand, is more of a bacterial infection. Oops, sorry guys. Okay. So I'll let you read that. Warm compresses are good for both of them though. This gets into the differences between the two, so just make sure you're aware of those. Conjunctivitis is most common. Again, remember there's different types of conjunctivitis, so just make sure you're conscientious of what each conjunctivitis, how they present and how you treat. Remember, differentiate between conjunctivitis versus iritis, zoster, subconjunctival hemorrhage, or keratoconjunctivitis. Those are all differential diagnoses. Here is the breakdown again of the allergic versus bacterial versus viral conjunctivitis, okay? This one, bacterial, is the one that you see that looks the grossest, to be honest with you, because it gets the green, yellowy, crusty drainage from the eye. So when you see that, it's pretty indicative that it's bacterial. Viral, it's more red and a lot of tearing, but you don't see this yellowy, green, crusty stuff on the eye. And this is the one you really need to treat. Even though viral, it's not like you don't need to really treat it. Antibiotics don't really treat it, or they don't really give them. It's not required. You still want to keep the patient home from school or kid from school because it's very, very contagious. And lots of hand hygiene. Okay, so we have herpes simplex keratitis. You want to refer this patient to the ophthalmologist. Okay, so this is more complex and emergent ocular conditions. So remember, these are your emergency situations. Okay, so this one in particular, your dry eye syndrome. Usually it's 40 years old and older. In women, 50 in men. Sometimes it can indicate a systemic or autoimmune disease like diabetes, thyroid issues. The symptoms are usually blurred eye, blurred vision, lack of excessive tearing, gritty feelings. And there's a lot of diagnoses that can come with that, differential diagnoses. So conjunctivitis, blepharitis, contact lens complications, Bell's palsy. So you always want to just keep in mind your differential diagnoses when it comes to symptoms that are very, very generic. Okay, so your corneal abrasion, it usually occurs from scratching to the cornea. People usually know how it happened. It's very painful. It feels like they have a scratch in their eye, as well as blurred vision, sometimes redness, tearing, lid swelling. You just want to make sure that the pupillary function is intact, and if no history of trauma, you want to look for lesions of herpes and definitely refer to an ophthalmologist. So this is how you would evaluate and treat corneal abrasions, just like we watched our YouTube video on that. So please review that video if you have any questions about that. Again, foreign body in the eye, we already reviewed that in our YouTube video. Again, you want to make sure you look for the rustering if you're concerned about like any foreign body in there. You'll probably see that for a few days, even after the thing is removed, just so you know. So herpes zoster follows a dermatome just like you would see in a regular shingles outbreak. Obviously, it's a higher risk in older adults, immune compromised, and stressors. It is painful. So as soon as somebody gets this, they want to be put on the antivirals immediately. And also, to prevent vision loss, of course. Okay, so refractive errors is usually because of astigmatism, either being myopia, which is nearsighted, or hyperopia, which is farsighted, or presbyopia, which is age-related farsighted. It's not really an acute change in their vision. It sometimes it slowly develops. But again, you're just doing your basic testing with your Snellen chart and your pinhole test. And of course, if they require corrective lenses, you want to refer out to ophthalmology. Cataracts, we talked about. It's lens opacity. It's common in the older adult, it's progressive, and it's 50% worldwide blindness is due to cataracts and congenital form in newborns. So you have a lot of risk factors, including increasing age, diabetes, long-term corticosteroid use, trauma, excessive sunlight, any history of smoking and or alcohol abuse. All right, so ways to prevent it, primary prevention, basic stuff, guys. This is really basic stuff that you would educate your patients on, hopefully, when they're coming in for their primary care visits. So smoking cessation, protective eyewear, avoid high-risk activities. Tanning beds are a big no-no. If they are going in tanning beds, please make sure they're wearing their little sun eye protection in there. If they're doing any kind of welding or construction, they should be wearing eye protection as well as getting, obviously, especially as patients get older, they want to have regular comprehensive eye exams. So symptoms of cataracts are blurriness, glare with night driving, color perception is impaired, unilateral diplopia, and a glow or a halo around light. Those are your typical symptoms of cataracts. And you want to get that treated immediately or referred out immediately so that it doesn't progress. Okay, so glaucoma, another big progressive ocular issue that can lead to damage and can result in blindness. So it's there's two types: primary open angle and angle closure. Okay, and it's usually caused by intraocular pressures, an increase in intraocular pressure, which can damage the optic nerve, and it's obviously higher risk for older adults, and the most common cause of blindness in African Americans, and the second cause of blindness in Caucasians. So most common, it's initially asymptomatic in glaucoma, and it's just like a gradual onset of peripheral vision loss. Okay. When you do your fundoscopic exam, you're going to find an excessive cupping on the optic disc. Okay, so ocular emergency requires immediate treatment of the FNP to contact the ophthalmologist or send them to the emergency department. Okay, acute episodes of pain, redness, and acute vision loss untreated may lead to blindness within 24 hours. That's a big deal, guys. So if you see anything that's out of your realm and you just aren't sure, don't hesitate. Call 911 and get that patient to the emergency room. And do yourself a favor, call the emergency room before that patient even gets there to let them know that you are sending someone in with an ocular emergency so they can get their ophthalmologist specialist ready to go. Because ophthalmologist specialists in emergency rooms, they're not just hanging around all the time. They have to be called in. So you always want to try to get that notification to the emergency room before your patient gets there. Emergent care is really aimed, especially in a glaucoma emergency, is aimed at reducing intraocular pressure and opening the angle, which they'll do with these particular drugs listed here. Okay, so a detached retina, another huge ocular emergency. It's an immediate referral to an ophthalmology for surgery to prevent impaired vision or blindness. Usually it's a painless loss of vision, flashing lights and floaters, cobwebs in the peripheral vision, shadow or gray curtain moving across the vision fields. It does require immediate surgery, just so you know. Okay, so bleeding in the eye, you have hyphemia, and you have subconjunctival hemorrhage. It's somehow hyphemia is bleeding in the anterior chamber of the eye, and again, that's an emergency. So make sure you refer immediately out to the ophthalmologist. Okay. Damage to the retina as a result of glucose in the small vessels of the retina. This is diabetic retinopathy. Obviously, if you're diabetic, you want your diabetic patients going to the ophthalmologist and getting yearly checks. And if there's any changes in their visions, that needs to be addressed immediately. The biggest thing in preventing diabetic retinopathy is making sure that the blood sugars are on point, maintaining their glycemic control, avoiding any issues with hyperglycemia where their sugar pops up. That'll affect their vision, and it'll affect it acutely too. You'll notice that if your patient is hyperglycemic, a lot of the times their vision is blurred. You want to make sure that their HbA1c is less than 7%, okay, hopefully. You want to strongly encourage regular eye exams, and keep in mind that a diabetic on lisinopril, an ACE inhibitor, is shown to slow the progression of diabetic retinopathy. So use that as a choice when you're choosing, you know, an ACE inhibitor for your diabetic patient. Just keep in mind that that will actually also have double duty, and that it'll slow progression of diabetic retinopathy. Okay, so remember I showed you this picture in our intro. It's so important that you really visually grasp this. Here's your normal retina. So when you're looking into the eye, I mean, don't get me wrong, it takes a while to actually see all this. And when you first start looking in the eye, it's hard. It is. It'll take you. I once spoke to an ophthalmologist, and she told me it took her like 100 tries working before she actually could ever even totally visualize a normal retina. But at least on picture, you know by sight what it looks like. So normal versus diabetic. All right. Cotton wool spots. That's a big one. You want to know, be aware of cotton wool spots in the diabetic eye. Okay. So microaneurysms and the cotton wool spots are really big. Also, another thing with hypertensive retinopathy is something called arteriovenous nicking, which you will also possibly see as a question or a possible answer in terms of diabetic retina on your boards. Okay, macular degeneration, wet versus dry. We talked about this. Here's the Amsler's grid. AMD. There's no RX at this time for AMD, but they do recommend supplements like antioxidant vitamins and zinc. Okay, final thoughts. FNP often is the first to see the patient. So that's true. A lot of the times we are the first ones to see the patient. So we need to be very conscientious about identifying what's an emergency situation that needs to be referred immediately to prevent any further damage to the eye or, God forbid, blindness. Okay. You want to collaborate to confirm your diagnosis, especially on a complex patient. Get on the phone, call anybody that can help you diagnose this patient to get them the care that they need immediately. You know, you don't know what you don't know. And don't be afraid to ask questions, because the eye is its own beast, and you just, you know, you don't know everything. You learn a lot in NP school, but it's very different when you're in the real world. So you want to always have your resources and phone numbers to fellow NPs, just so you can always have resources to reach out to guide you. So you definitely want to try to practice with a fundoscope whenever you can. Like I said, it's really hard to see a normal eye retina when you first look. It's going to be hard to, you know, look at those particular particular, what do you call it, like markers when to really figure out what you're looking at. But if you do it frequently enough, at some point you'll get it. And eye specialist directs care for complex ocular conditions. You just need to make sure you understand comprehensive care and primary care and other settings in terms of like what your primary care setting actually provides in terms of ocular care. So just keep that in mind. You need to know what your practice offers and when you need to refer out and who you would refer to. And that's it, guys. Thank you so much. I hope this was helpful, and I will see you next week.